Okay. So good evening, good evening, good evening. Sorry, the mic was closed, and now I think I am audible, visible. Is everything is fine now? Yeah. Yes. Okay. So I was also very much eagerly waiting to see you all, and very happy to see the enthusiasm that you are having. Uh, I hope that you are all keeping with your nerves and the things this very crucial time, these last 10-15 days towards any exam becomes very important. And both Sara, we feel a lot of time that it's we are not able to keep up with the same momentum. It is very much normal, don't worry. In the exam also, if sometime we don't know any answers, maybe continuously 3 4 5 questions, there is no need to worry. There are easy questions are there, and you will have to make sure that the easy questions you are marking right, right. uh, the exam, when the exam will be and all these things, let's keep it very simple. Let's it be on the 6th of July. We are going to prepare like this only. And will not take you much time. It is going to be a very crisp session as we did also the last time. So I will tell you the buzzwords that if that is there, the most likely answer will be this one. So starting with the first one, don't worry guys. Uh, I'm not able to read the chat box very frequently as I'm not very acclimatized to the system, but let's get started. When it comes to the classification of amino acid, there are 3 4 important questions from classification. One, that they will say that there is amino acid. We keep the amino acid in the sunlight, and they will give you some UV rays. They will not write the UV rays word, but they will say that they will say about this thing, the light frequency. They will tell you that we are having a certain light frequency, we are putting some amino acid, which one is going to absorb that light maximum. The moment you see that thing, the light rays is there, and they are saying that who is going to absorb the maximum. Basically they are talking about the UV rays absorption, and the maximum UV rays absorption, it is in tryptophan. So वो UV rays का, they will give you the frequency, maximum UV rays absorption, tryptophan. The second thing to be remembered is the most glucogenic amino acid. The most glucogenic amino acid among all of them, it is alanine. Gluconeogenesis, there are two important questions. One, which is the most common source for gluconeogenesis? It is alanine. And which is not a source of gluconeogenesis, not a source of gluconeogenesis? The answer is going to be acetyl-CoA. So these are the two important questions. I will share the PDF. I will share the PDF with you. That is fine, and that will come to you. So you don't have to write anything. Just be with me for next 1.5 hours, and we'll take care you of majority of the part of your biochemistry. The second is the relation of SGOT, SGPT, clinical relation of SGOT, SGPT. See, these are the liver enzymes, and we always see whenever there is any liver damage, whether it is because of alcohol or it is because of other than alcohol, whether it is alcoholic or non-alcoholic, the SGOT, SGPT is going to increase. So we have to see that which enzyme has increased more. If SGOT has increased more, means the ratio of SGOT SGPT is more than 2, that is alcoholic liver disease. So keep it simple. SGOT, if it is twice higher, it is going towards alcoholic. But if the SGPT is more, it is non-alcoholic, such as hepatitis A, dengue, इन सब में ऐसा होगा. SGOT जो होता है, it is found at 3 places. SGOT is found at 3 places: liver cell, skeletal muscle, and cardiac muscle. That is why in the myocardial infarction also the SGOT is going to increase. So if they ask that which enzyme is going to increase in myocardial infarction, that is troponin is there, the LDH is there, and one more you need to remember is SGOT, right? Let's go to the next one. When it comes to urea cycle, what is happening is in our body, when whatever amount of protein we are having, we are metabolizing the protein and we are making the ammonia. This ammonia is very toxic, so it is supposed to be converted into urea, and then this urea will be excreted out. So this conversion of ammonia to urea, it is mainly occurring in the liver. So we can say like that the factory of converting the ammonia into urea is in the liver. So how this ammonia is getting converted? It is taking total 5 steps. There are 3 questions to be remembered. There are total 5 steps. The first question, the conversion of ammonia to urea, which is called as the urea cycle, it occurs where? It is mainly occurring in the liver. This is the first thing. The second is there are total 5 reaction. Out of 5 reaction, you can see first 2 reaction in the mitochondria and the remaining 3 reaction in the cytoplasm. So there are total 5 reactions, means there are total 5 enzymes will be there. So here you can see the first enzyme is the CPS1 in the mitochondria. The second enzyme is ornithine transcarbamylase in the mitochondria. The remaining 3 enzyme, the arginosuccinate synthetase, arginosuccinase lyase, and arginine hydrolase, that is there in the mitochondria cytoplasm. So what they ask is all of the following enzyme of urea cycle is found in the mitochondria except. So we should know that which one is mitochondrial, which one is cytoplasmic. How we are going to remember? The enzyme which is starting with alphabet A, these are cytoplasmic. जो भी A से चालू हो रहा है, these are cytoplasmic. Remaining is the mitochondrial. Whatever starts with the A, that is cytoplasmic. Remaining is mitochondrial. The third and last question, the rate limiting enzyme is CPS1, but it is not activated. To activate it, we require a molecule called as NAG, N-acetyl glutamate. So they ask this question, who is the sixth enzyme of urea cycle? There are only 5 reactions, but who is the sixth enzyme? The sixth enzyme is NAG. So there are 3 questions to be remembered. Urea cycle occurs where? Liver. Total how many reactions? 5 reactions, 2 in the mitochondria, 3 in the cytoplasm, and cytoplasmic enzymes it starts with the alphabet A. What is the name of the sixth enzyme? The name of the sixth enzyme is actually is the activator of the CPS1, that is NAG. NAG is considered as the sixth enzyme, and acetyl glutamate is considered as the sixth enzyme. Okay. Let's move forward. The next is the concept of the phenylketonuria. We know that phenylalanine converts into tyrosine, and from tyrosine we can make melanin. To convert the phenylalanine to tyrosine, we require the phenylalanine hydroxylase. Sometimes in some children, this enzyme is not there. If this enzyme is not there, the reaction will not occur properly. If this reaction will not occur, the phenylalanine will start accumulating and the tyrosine will be depleted. If the tyrosine will be depleted, the melanin will not be synthesized and the child will have relatively fair complexion. Now, there is increase in the phenylalanine that is going to trigger alternate pathway and it will convert into the ketone body of the phenylalanine. These are called as the phenyl acetate, phenyl pyruvate, phenyl lactate, and they will start coming in the urine. And because the phenyl ketone bodies are coming in the urine, so this disease is called as phenylketonuria. And interestingly, one ketone body is phenyl acetate. It has a very bad smell. It smells like mouse. So this child urine will have the mousy smell. What are the 3 symptoms to be remembered is, see, nowadays they have stopped saying the word mousy smell. They will use the alternate thing. One thing they will say that the mother is saying that whenever the mother is changing the diaper is having a very bad smell. Instead of mousy smell, they will say very bad smell. This child will have a decreased IQ also and a relatively fair complexion than other family members. So these are the 3 things to be remembered. Mousy smell, instead of that there is a bad smell, but bad smell किसकी वजह से आता है? The bad smell is due to phenyl acetate. So bad smell is because of phenyl acetate. IQ is less, fair complexion, it is phenylketonuria. One more thing, phenylketonuria symptoms are not there on the day 1 of life. They will come after 3 to 4 days. So sometimes they can say phenylketonuria child is absolutely normal at birth. Yes, the child is absolutely normal at birth. The symptoms are not going to be there on the day 1 of the life because the maternal enzymes are there. They can do the task. But let's don't go into the concept of that, but keep it simple. If these are the 3 things: fair complexion, decreased IQ, bad smell, it is phenylketonuria. The child will have no problem on day 1 of life, and we do one test called as Guthrie test to diagnose this. Okay, very good. The next is the question on the tyrosinemia. It's a very hot favorite topic. See how the tyrosine is getting metabolized. Tyrosine say we are having 3 molecules: melanin, thyroid hormone, and catecholamines. Catecholamines means the norepinephrine, epinephrine, dopamine we are making from tyrosine. So these are the 3 important molecules. This is itself a MCQ, that tyrosine is made from which amino acid? Melanin. When the tyrosine is extra, that tyrosine has to be cut down. And how we are going to cut down the tyrosine is like this. We'll break the tyrosine by this pathway. If by any chance, if any enzyme is not there in the pathway, the tyrosine will not cut down and the tyrosine will accumulate, and that is called as tyrosinemia. For example, in this list, if you look at this enzyme FAA hydrolase, if it is not there, the reaction will not happen, and ultimately the tyrosine is going to accumulate. Ultimately, the tyrosine is going to accumulate. So that is going to be called as the tyrosinemia. That is going to be called as tyrosinemia. In fact, if any enzyme is not there, that will be called as a tyrosinemia. So we should know that what are the various tyrosinemias and what are the various tyrosinemias. Plus, we should also know that what enzyme deficiency they are carrying. See here, it is very simple to remember. If they say tyrosinemia type 1 is due to deficiency of what? Tyrosinemia type 1, that is going to start with the letter F, FAA hydrolase. Tyrosinemia type, instead of 1, you can remember is first. Tyrosinemia type first is due to the enzyme which is starting with the letter F. Tyrosinemia type 2, it is due to deficiency of tyrosine transaminase. So it is called as T2. हम ऐसा याद रख लेंगे. Type 1 is first starting with the letter F. Type 2 is T2. And type 3 is going to be 4-hydroxyphenyl pyruvate deoxygenase. So we can remember 3,4. So 1 is starting with the letter F, 2 is T2 and 3 is 4. But here is now there is a tricky part. The tricky part is sometimes instead of tyrosine transaminase, everyone pay attention here. Sometimes instead of this enzyme tyrosine transaminase, they can use the word tyrosine aminotransferase. They can use the word aminotransferase. But the thing is simple. Instead of transaminase, they are using the word aminotransferase. That is more or less the same, right? So that you have to keep in mind while using this mnemonic. Very good. The next is the concept of L-ketonuria. There are three things again to remember in L-ketonuria. What we do is actually whenever we see the dark urine, we jump to the L-ketonuria. That should not be the right approach. The problem with the dark urine is the moment you see dark urine, you jump on L-ketonuria. Always you have to see the associated symptom. Is it associated with the joint pain? Is it associated with abdominal pain? Or is it associated with muscular pain? So dark urine can be seen in three conditions. If they say dark urine with joint pain, they are talking about L-ketonuria. If they say dark urine with abdominal pain, then they are talking about acute intermittent porphyria. If they say dark urine with muscle pain, severe muscle pain followed by dark urine, they are talking about myocardial disease. So dark urine देखते ऐसे L-ketonuria पे don't jump on L-ketonuria. See, any of the three can be there. Plus, now let's look at the name of the enzymes also here. L-ketonuria is due to deficiency of homogenetic acid oxidase deficiency. Deficiency of HG oxidase. Acute intermittent porphyria, it is due to deficiency of PBG deaminase. PBG deaminase deficiency. Myocardial disease, it is due to deficiency of muscle glycogen phosphorylase. Muscle glycogen phosphorylase deficiency. So dark urine joint pain के साथ में आ रहा है, it's L-ketonuria. Abdominal pain, acute intermittent porphyria, and muscle pain, myocardial disease. Now let's focus on L-ketonuria part as of now. Sometimes when the tyrosine metabolism is happening, we generate this homogenetic acid that is supposed to be metabolized by this HG oxidase. If it is not there, the HGA is going to increase. Homogenetic acid is going to increase, and that is going to make a molecule called as benzoquinone acetate that will start coming in the urine, that will make the urine dark, and that is going to deposit in the cartilage, and that is going to destroy the cartilage called as ochronosis. In this entire disease, there is no mental retardation. It's a very important MCQ. What they will say is all of the following are the symptom of L-ketonuria except mental retardation is not a symptom. In L-ketonuria, we don't have mental retardation. We don't have mental retardation. Two very important MCQ. In L-ketonuria, we don't have mental retardation. Plus, for the treatment of L-ketonuria, we give a drug that is nitisinone. The treatment of L-ketonuria, the drug that we are using is nitisinone. Very good, Mukul. The next is From the tryptophan, we are making several special products. From tryptophan, the special products that we are making is such as vitamin B3, niacin, we are making serotonin, and we are making melatonin. This is itself is a MCQ that serotonin is made up of what, vitamin B3 is made from what, melatonin is made from what, they are made from tryptophan. Now, when the tryptophan, as I am saying that from tryptophan we can make niacin, as well as from tryptophan we can make the serotonin. From tryptophan to serotonin, it occurs in the argentaphin cells. Sometimes there is a tumor of the argentaphin cells that is called as argentophenoma, or also called as carcinoid tumor. In that case, all the majority of the tryptophan will be diverted towards this part because the argentaphin cells are working more. And if all these will be shifting towards this side, a very less tryptophan will go towards the niacin synthesis. So this patient will have the niacin deficiency, that is pellagra like symptoms. One more thing that is going to happen is because all the tryptophan has been diverted this side, so a lot of serotonin will be made. And because of increase in the serotonin, the patient is going to have the facial flushing, means there is going to, the face will turn red. There is going to be increase in the intestinal motility, that is diarrhea. Plus, it can lead to bronchospasm. So in any MCQ, if you see there is facial flushing, face ekdam लाल हो जाता है, the patient is having continuous diarrhea and the bronchospasm, then they are talking about the carcinoid. You remember like this, flushing with diarrhea, flushing, diarrhea, flushing, diarrhea. Flushing means face turns red, that is flushing. Flushing, diarrhea, it is carcinoid. It is carcinoid, and this patient will also have the symptoms of pellagra-like symptoms. Pellagra-like symptoms like dermatitis, dementia, that can also be there. One more thing to be remembered in carcinoid, what we have discussed is that in carcinoid, there is excess serotonin. Excess serotonin converts into excess amount of 5-hydroxyindole acetic acid. A lot of 5-hydroxyindole acetic acid will be formed, and that will come in the urine. So whenever we are suspecting carcinoid, we check the level of 5-HIA. This is again MCQ, that how to confirm the carcinoid. We are going to check the 5-hydroxyindole acetic acid level. We are going to check the 5-hydroxyindole acetic acid level. Very good. The next is the hyperhomocystinemia. Increased level of homocysteine is called as hyperhomocystinemia. What are the points to be remembered is, one is, what is the most common cause? The most common cause is deficiency of this enzyme cystathione beta synthase. If there is deficiency of cystathione beta synthase, this is the most common cause of hyperhomocystinemia. The most common cause. The second point to be remembered is ki if there is increase in the homocysteine, how we are going to make a diagnosis? See, one thing is the patient body features will be like this. The fingers will be long, the arm length will be more, there will be ectopia lentis. These things will be there. That is called as Marfanoid habitus. So if the homocysteine is more, the patient will have the body features looks like Marfan syndrome. But homocysteine also increases the thickness of the blood. There is increase in the coagulability of the blood. So that can lead to deep vein thrombosis. If you look at these two parameters, Marfanoid habitus plus deep vein thrombosis, Marfanoid habitus plus DVT, then it is going towards hyperhomocystinemia. Hyperhomocysteine. So if there is increase in the there are two questions to be remembered. Again, I am repeating two questions, very important. Everyone remember here itself. They will say the most common cause of hyperhomocystinemia, the most common cause is deficiency of cystathione beta synthase. Second, how to make a diagnosis that homocysteine is more. The body feature will be like Marfan syndrome, and along with that, they will give you the history of the pain in the calf muscle, that is DVT. In fact, in any MCQ of biochemistry, they talk about DVT, they talk about the calf pain. They are talking about basically is the homocystinemia. Homocystinemia. Very good. Now coming to the protein, this is all about from the first major unit, that is amino acid. Now coming to the second one, protein. Protein may 2-3 points only. One, if you are having two proteins, let's say there is one protein in the secondary structure, another protein in the secondary structure, and we want to join them. So you are either you will take a short chain of amino acid to join them, or you can take a long chain of amino acid to join them. If you are taking a short chain of amino acid to join the proteins, it's called as turn and bend. And if you are taking a long chain, it's called as loop. So the question that will come to your exam will be turn and bend. We understand it's a short chain of amino acid. They will say that it is made up of which amino acid. What are the amino acids here in turn and bend? The turn and bend, the amino acids are proline and glycine. And interestingly, both will be there in the choice. So you have to select proline. The question will be like this: turn and bends are made up of what? They are made up of proline. Keep it very simple. Turn and bends are made up of what? They are made up of proline. Done? Okay. The next is the collagen disorders. If the type 1 collagen is defective, type 1 is making the bones sclera. So if the type 1 is defective, the bones will be defective. The child will have recurrent fractures, that is called as osteogenesis imperfecta. So the child will have multiple fractures. Sclera will be very thin. So on the back side of the sclera, we have the venous plexus that will be visible. That is called as the blue sclera. So multiple fractures, the sclera will turn blue because the sclera is very thin, and the child may have the hearing loss also. So this is the triad that we see in osteogenesis imperfecta: multiple fracture, blue sclera, and hearing loss. Coming to the type 2, if the type 2 is defective, type 2 is there in the cartilage. If the cartilage is defective, it is called as chondrodysplasia. Chondrodysplasia. The type 4 is defective. Type 4 is there in the basement membrane. It is itself is MCQ. That type 4 collagen, it is found where? It is found in the basement membrane. If the type 4 is defective, it will lead to Alport syndrome, and the classical triad of Alport syndrome: hematuria, SNHL, and anterior lenticonus. There is going to be hematuria, SNHL, and anterior lenticonus. There is one more condition which is very similar. If they say a patient is coming to us and he is having hematuria with hemoptysis, then what is happening is there is no problem with the type 4 collagen. Actually, there is a wrong antibody against the type 4 collagen. So that is the autoimmune destruction of the type 4 collagen. Autoimmune destruction of the type 4 collagen, and that is called as the, yes, very good, that is called as Utkarsh Goodpasture syndrome. So Goodpasture syndrome and Alport syndrome, they are quite similar. The difference is in Alport syndrome, the type 4 collagen itself is defective. And in Goodpasture, the type 4 was normal, but there was a wrong antibody that is destroying the type 4 collagen. गलत antibody type 4 collagen को खराब कर रहा है. That is Goodpasture, and that way we are going to have the hematuria with hemoptysis. Okay. Very important, isomerism. It's a very important topic. Isomerism. What is isomerism? Is basically there is going to be same molecule with different structures, and that is they can making the different molecules. Formula is same. Formula is same. For example, glucose formula is C6H12O6. From the same formula, we can make the different molecules. That is called as isomerism. I want you to remember one example. If you can remember all the example, very good. If not, remember glucose and mannose, they are isomers. They are which type of isomers? Epimers. So glucose and mannose, they are epimers. And how the glucose and mannose are different? You just have to rotate the HOH at which carbon? If it is the glucose molecule, and you if here is the H, here is the OH, if you just rotate the HOH at the carbon number 2, the molecule that will be formed is called as mannose. So glucose and mannose, they are epimers. They are epimers at which carbon? Carbon number 2. So the language of the question will be, what is the relation between glucose and mannose? They are carbon 2 epimers. Carbon 2 epimers. One more. What is the relation between glucose and galactose? They are carbon 4 epimers. If you rotate the HOH at carbon number 4, if you rotate the HOH at the carbon number 4 of glucose, the molecule that you are going to get is galactose. So glucose and mannose, they are epimer at carbon number 2, and glucose and galactose, they are epimer at carbon number 4. Carbon number 4. Right? To be remembered. Very good. Let's go next. The various types of GAG, glucosaminoglycans. Keep it very simple. Which GAG does not contain hyaluronic acid? Which GAG does not contain uronic acid, glucuronic acid? Which GAG does not contain acid? The GAG which is found in your cornea does not contain acid. The answer is keratan sulfate. Carat means cornea. I will tell you two questions. Super important. One, which GAG does not contain acid? Keratan sulfate. It is found in cornea. And what it is doing? It is maintaining the corneal transparency. It helps in maintaining the corneal transparency. The cornea is transparent because of keratan sulfate. So, 2 points. Which gag does not contain acid? The gag which is found in the eye, that is keratan sulfate. Plus, the which gag helps in maintaining the corneal transparency? Corneal transparency again is the keratan sulfate. Very good. Let's move forward. The glycolysis. When it comes to glycolysis, they ask this question that when we do the sugar estimation, if we want to check the blood sugar, let's say here is the blood sample, and I want to check that how much glucose is there in this blood sample, how much glucose is there. Then when we want to estimate the glucose in the blood sample, we don't want the glycolysis to occur in the blood sample, because if the glycolysis will occur, the glucose will go down, right? And we will not get the correct value. So in all the blood samples, we want to stop the glycolysis, and to stop the glycolysis, we add one toxin that is called as the fluorides, sodium fluoride. They don't write the word sodium fluoride, they just write the word fluorides. So for the correct glucose estimation, which toxin is added in the blood sample? Fluorides. And fluorides inhibit which enzyme of the glycolysis? Enolase. So two questions from fluoride. Fluoride is used for the correct glucose estimation. For the glucose estimation, we use the fluoride. And in the test tube, we are adding this fluoride that is going to inhibit which cycle of the glycolysis? It is enolase. Very good. In the glycolysis, the total amount of ATP that is generated is 7. And in glycolysis, we are cutting the glucose. What do you think? Can you tell me in the chat box? Okay, this is the first question from my side in your chat box, that in the glycolysis, what will be the effect of insulin? The insulin is going to stimulate or it is going to inhibit? Insulin is going to stimulate the glycolysis or inhibit the glycolysis? Insulin is going to stimulate or inhibit? Yes, write down in the chat box. Insulin is going to stimulate the glycolysis or inhibit the glycolysis? It is going to, yes, it is going to stimulate the glycolysis. Yes, it's going to stimulate. It's going to stimulate beta. See, in any pathway, if you are cutting the glucose, see, insulin kya chahta hai? Insulin wants to decrease the glucose level. Insulin wants to decrease the glucose level. So in glycolysis, what you are doing? You are cutting the glucose. Insulin wants the same, right? So insulin is going to stimulate all such processes. Insulin wants to stimulate all such processes where you are cutting the glucose. Wherever you are cutting the glucose, insulin is going to stimulate. So a question aayega. See here, they will ask either for glycolysis or they will ask for gluconeogenesis. That what will be the effect of insulin? In glycolysis, basically we are doing is we are cutting the glucose and we are making pyruvate. So insulin to yahi chahta hai. Insulin wants to cut the glucose. So insulin should stimulate such process. Insulin should stimulate such process. But when we talk about gluconeogenesis, in gluconeogenesis, what is happening? From alanine, let's say you are making glucose. Insulin never wants the glucose to be made. So what is going to happen with the effect of insulin on gluconeogenesis? Inhibit. In all the reaction where the product is glucose, insulin will stop such process. And in all the reaction where you are cutting the glucose, insulin bolega karo karo. Very good. And the opposite of insulin is glucagon. The opposite of insulin is glucagon. Right? Okay, very good. The next thing, very good. The next is the Krebs cycle. In the Krebs cycle, there are some toxins to be remembered. First thing first, from the Krebs cycle, we are going to generate 10 ATPs. From one Krebs cycle, we generate 10 ATPs, and the Krebs cycle occurs in the mitochondria. There are various toxins which can inhibit the Krebs cycle, but the most important for us is the malonate. The malonate inhibits the succinate dehydrogenase enzyme. Malonate inhibits the succinate dehydrogenase. I will tell you three questions from Krebs cycle. One, how much ATPs? 10 ATPs. Where it is occurring is the Krebs cycle. Krebs cycle is occurring in the mitochondria and we are getting the 10 ATPs. Second, malonate inhibits which enzyme? Succinate dehydrogenase. Third question. See, in our cycles, we are generating the energy either in the form of ATP, NADH or FADH. So they ask this question, in which whenever we generate the energy in the form of ATP, NADH or FADH, But whenever we are generating the energy directly in the form of ATP, such reactions are called as substrate level phosphorylation. Whenever you make ADP, that is called as SLP, substrate level phosphorylation. And in the Krebs cycle, the substrate level phosphorylation is only occurring once, So they ask that what is the name of the enzyme and what is the name of substrate when we are doing the substrate level phosphorylation. The name of the enzyme is succinyl thiokinase and the name of the substrate is succinyl-CoA. Remember it. If you can't remember both, remember the language will be like this. Which of the following is a substrate for substrate level phosphorylation in Krebs cycle? What is the name of the substrate for substrate level phosphorylation? Succinyl-CoA. Remember it. Very good. The next is they will give you the reaction where we are converting the pyruvate into acetyl-CoA. That is going to be a structure based question. They will give you a carbon structure molecule, 3 carbon structure, and from that you are making the 2 carbon structure. There will be a different complex carbons will be there, and multiple structures will be there. What they will ask is there are 3 enzymes which are doing this reaction, E2, E1, E2, E3, and they will ask you what is the name of E1, what is the name of E3. The name of the E1 to be remembered, that is there in their question bank, it is pyruvate dehydrogenase, and E3 is dehydrogenase dihydrolipoyl. In fact, I will tell you the easy way to solve this question. If this question comes, they are giving you a 3 carbon structure. From that, you are making 2 carbon structure, and they will say what is the name of enzyme E1 and E3. Just remember the option which is saying the dehydrogenase. E1 also contain dehydrogenase, E3 also contain dehydrogenase. There is only one option in the Q bank where the E1 and E3 both means there is only one option which is having dehydrogenase 2 times. So you will select the option where you are having the dehydrogenase. That is going to be the answer. The next is the von Gierke disease. The clinical questions will be like this. They will not ask you the diagnosis of von Gierke. They will give you a clinical scenario and they will ask you that which of the following statement is not true for von Gierke disease. They will give you the clinical scenario, they will give you the diagnosis also, and then they will ask which of the following is not correct for von Gierke. See, what is the meaning of von Gierke is they will give you a child and they will say that whenever the mother forgets to give a meal, the child goes into hypoglycemia. If a child is going into hypoglycemia, the answer is going to be von Gierke disease. Now, von Gierke disease, what are the points to remember? It only affects liver. It does not affect muscle. The first thing, it only affects liver. Second, in the von Gierke disease, there is increase in the lipid, there is increase in the uric acid, there is decrease in the glucose. Hyperlipidemia, hyperuricemia, but there is hypoglycemia. The glucose is less. In von Gierke disease, lipid is more, uric acid is more, but the glucose is going to be less. This child will have decrease in the growth. The growth will be less. So these are the points to be remembered. They will ask you a all except question that all of the following are true except there is going to be increase in the lipid, there is going to be increase in the lipid, increase in the uric acid, but the blood glucose will be less. Blood glucose will be less. In fact, in any MCQ of biochemistry, a child is going into hypoglycemia. It's von Gierke. It's due to deficiency of glucose 6-phosphate dehydrogenase. Sorry, the glucose 6 it is due to glucose 6 phosphatase. Due to glucose 6 phosphatase, the glucose 6 phosphate is unable to convert into glucose. As I told you right now about the glucose 6 phosphate dehydrogenase, that is a different one that is used in the HMP shunt that you have discussed in the pathology also, that is referred as G6PD. So we all know that if there is a deficiency of G6PD, the patient develops anemia. That is the hemolytic anemia. There are two questions from this particular statement. They will tell you like this. The hint in the MCQ will be like this. They will say that the patient has started on a particular drug, and after starting that drug, the patient has developed anemia. After starting a drug, the patient is developing anemia, and generally that drug is going to be primaquine. For malaria, we started primaquine. Next day, the patient was having anemia because the G6PD was not there, and it is a X-linked recessive disorder. Super important. What is the inheritance pattern of G6PD? It is X-linked recessive. It's a X-linked recessive disorder. So it's only going to affect males. Very good. The next is the myocardial disease. Although I have told you 3 points already about the myocardial disease, that whenever they say the patient is doing some physical exertion, if they say the patient is doing, the hint will be like this: the patient is doing some physical exertion, either the patient is going into gym or going in the staircase, physical exertion followed by muscle pain, followed by dark urine. Physical exertion followed by muscle pain, followed by dark urine, it is myocardial disease. Physical exertion followed by muscle pain, followed by dark color urine, it is myocardials, and myocardials is due to deficiency of muscle glycogen phosphorylase. Muscle glycogen phosphorylase. In fact, they can ask you the treatment of this disease also. For the treatment of this, we try with the vitamin B6. We give vitamin B6. If that works, very good. If not, then the enzyme replacement therapy. Initially, we are going to give vitamin B6 if that works. If not, we are going to give the enzyme replacement therapy. Let's move forward. The next is galactosemia. Galactosemia, they will give you a clinical scenario like this. Whenever the breastfeed is given to the child is having vomiting. Breastfeed followed by vomiting, it is galactosemia. And we have remembered a mnemonic, if you remember in the class, FABGUT. Galactosemia, it is due to deficiency of galactosemia is due to deficiency of uridyl transferase. So the breastfeed followed by vomiting, the answer is going to be galactosemia, but definitely they will not ask you the diagnosis, but they will go forward. Galactosemia, it is due to deficiency of uridyl transferase. There is increased risk of E. coli infection. There is oil drop cataract. There is going to be oil drop cataract, and that is due to deposition of calcititol. Calcititol. So I want you to remember these 3-4 points. One, it's due to deficiency of uridyl transferase. There is increased risk of E. coli infection, and the child will develop the oil drop cataract. There is going to be mental retardation. These things will be there, because nowadays they have stopped asking the question like this. They will give you more of such questions. Listen to the words. The question language will be like this. You Most of the questions will not be the one liner type of pattern. The questions will be maybe like this: all of the following are true about this disease except. So you should be knowing the three facts. The fourth one is going to the answer. So you have to apply the concept, you have to apply the things, then only we are going to crack the things. So if you know the core crux. So these are the important points to be remembered from the galactosemia part. If they say this is galactosemia, breastfeed followed by vomiting, but if they say fruit juice followed by abdominal pain, then this is fructose intolerance. And fructose intolerance is due to deficiency of aldolase B. Aldolase B. The mnemonic we have discussed was FABGUT. Fructose intolerance is due to aldolase B deficiency. Galactosemia is due to uridyl transferase deficiency. Galactosemia is due to uridyl transferase deficiency. Fructose intolerance, aldolase B deficiency. Right? Okay. Let's move forward. The next is the Gaucher disease and Fabry disease. I will not go into, see, it's the reason I'm going fast. The reason I'm just focusing on the keywords, because I don't want you to lose and invest your precious time in these things. I want to keep the things very straightforward. If this thing will come, that is going to be the answer. If this thing will come, that will be going to be the answer. It's not a class to learn the concept, right? We will not dig down the things in this short session. So that is why I am compelled to do the things in this way. And if you are not able to write down the things, nothing to worry. The file will be shared with you in a while just after the session. Plus, I want one thing from you is, when you are there with me for next this 1 hour, try to get involved and try to remember the words what I am saying. If this will be there, the answer is this, right? And try to remember that as much as possible. So the next is going to be a 8-year-old child. The hemoglobin will be 6.5. The exact values are there. 8-year-old, hemoglobin is less, and hepatosplenomegaly. 8-year-old child, hemoglobin is less, hepatosplenomegaly, the bone marrow biopsy was done, and there was a special cell that is there. The image is not like this, there is a slightly different image, but it is going to be there. It is, even I will tell you, it is going to be like this, and they will ask you that we understand that in a child, anemia, hepatosplenomegaly, but the bone marrow is showing this crumbled tissue paper appearance, it is going towards the Gaucher disease. But what they are going to ask is not the diagnosis. They will say that it is due to which enzyme deficiency. It is due to deficiency of beta glucocerebrosidase, and this is the exact name of the enzyme that is there. Deficiency leads to Gaucher, but in their question bank, the beta word is missing. The answer is going to be glucocerebrosidase. Glucocerebrosidase. If it is there, if the beta glucocerebrosidase is there, that is the best answer. But in that, the beta word will not be there. The beta word will be there, but the name of the enzyme after the beta word will be different. Say, for example, one option will be beta galactocerebrosidase, and one option will be glucocerebrosidase. These two options will be there, beta galacto and glucocerebrosidase. Then you are going to select glucocerebrosidase because the answer is beta glucocerebrosidase. Although the beta word is not there, okay, then we will select the beta. We'll select the glucocerebrosidase. We'll not select galacto. Any day we are not going to select galacto. Okay, very good. In any MCQ, if they use the word angiokeratoma, the moment you see the angiokeratoma, the answer is Fabry disease, and it is due to deficiency of alpha galactocerebrosidase. Fabry. Alpha, Fabry, alpha, Fabry, angiokeratoma, and it is a X-linked recessive disorder. In biochemistry, there are only few disorders which are X-linked recessive, and we have already discussed two out of them. One is G6PD, and second is Fabry disease. Let's move forward. Okay. See, normally the fatty acids are metabolized in the mitochondria. Normally the fatty acids are metabolized in the mitochondria, but to enter inside the mitochondria, we require a transporter, and the name of this transporter, which is there on the mitochondrial membrane, inner mitochondrial membrane, this is CAT, carnitine acyl transporter. So there is a CAT which is sitting there to transport the fatty acid from the cytoplasm to mitochondria. So one question, who transports fatty acid from the cytoplasm to mitochondria? The answer is CAT. The full form of CAT, it is carnitine acyl transporter. Remember this image. This image will help you. Carnitine acyl transporter. Carnitine acyl transporter, CAT. Now what happens is, if the fatty acid is very big, the CAT cannot transfer the fatty acid in the mitochondria. If the fatty acid is very big, that is called as a very long chain fatty acid. If the fatty acid is very big, if we have the very long chain fatty acid, then that cannot enter in the mitochondria, then it has to go in the peroxisome. So one question will be like this, very long chain fatty acid metabolism occurs where it is occurring in the peroxisome. So two questions, who transport the fatty acid from the cytoplasm to mitochondria? CAT. But it cannot transport a big fatty acid. So the big fatty acids, they will go where? They will go in the peroxisome. They will go in the peroxisome. Very good. The next is, in any MCQ, if they say corneal transparency, okay, I will use the word corneal clouding. If they use the corneal clouding word, you have to see whether it is present or absent. If the corneal clouding is absent, the answer is Hunter disease. And if the corneal clouding is present, the answer is Hurler disease. In the MCQ, if the options are saying Hunter or Hurler, search for corneal clouding. If the corneal clouding is present, it's Hurler. And if it's not there, it's Hunter. Because you understand, a hunter always has to have a very good eyesight. Then only he can be a hunter. So hunter has a very good cornea. The corneal clouding is not there. The cornea is clear in a hunter. And hunter is X-linked recessive. So this is the third disorder in the biochemistry for us. X-linked recessive is hunter. In hunter, no corneal clouding. If the corneal clouding is there, it's hunter. Very good. The next is the HGPRTS deficiency. If there is deficiency of HGPRTS, the patient will have a significant mental retardation and self-mutilation. The child will eat out its own finger. The child will eat out its own finger. It's Leschnian syndrome. The moment you see self-mutilation in biochemistry, it's Leschnian syndrome. It's due to deficiency of HGPRTS, and interestingly, this is the X-linked recessive disorder. This is another X-linked recessive disorder. If there is deficiency of adenosine deaminase, it leads to severe combined immunodeficiency disease. SCID, severe combined. Why it is combined? Because the T cell and the B cell both are affected. So it's a combined immunodeficiency. So two questions from purine catabolism. If the HGPRTS deficiency is there, it's Leschnian syndrome. Adenosine deaminase deficiency, it is severe combined immunodeficiency. SCID. Adenosine deaminase deficiency leads to SCID. We all know that the DNA is there in the nucleus, right? Now, how this DNA get fit into the nucleus? We take the DNA, we turn around the histone, and then we fit in the nucleus. So DNA and histone, they are in very close proximity. DNA and histone, they are very closely related because DNA को हम histone के चारों तरफ लपेटते हैं. We turn the DNA around the histone. So DNA histone, very good relationship. In fact, if you want to do anything on the DNA, you have to take the permission from histone. For example, from DNA you want to make RNA, that is transcription. If you want to do transcription, you have to take the permission from the histone. You have to take the permission of histone means if you want to do activate the transcription, you have to do the acetylation of histone. If you want to stop the transcription, you need to do the methylation of histone. So acetylation, remember everyone, acetylation leads to activation of transcription. If you do the acetylation of stone, if you give a lot of acetyl group on the stone, the transcription will happen. If you want to stop it, methylation. Methylation is not important for your exam. They will say which process will activate the transcription, it is acetylation. Which process will activate the transcription, acetylation. Very good. The next is the DNA repair disorders. DNA repair disorders. If there is a mismatch, means normally what happens is the in the DNA, A clubs with the T and G clubs with C. This is normal. A clubs with T, G clubs with C. But by any chance, if there is a mismatch and that has not been corrected, the patient will develop something called as the HNPCC, hereditary non-polyposis colon cancer. If there is a mismatch repair defect, if there is a mismatch, the patient will develop the HNPCC, hereditary non-polyposis colon cancer, also called as the Lynch syndrome. Mismatch repair defect leads to colon cancer. In their Q bank, the answer is like this. They will say there is a mismatch repair defect. It will lead to what? And the option is HNPCC. HNPCC, CC stands for colon cancer. Mismatch repair defect will lead to HNPCC. For colon cancer, there are 2-3 points to be remembered further. One is from the medicine that colon cancer is the most common cancer of acromegaly. In a patient of acromegaly, the most common cancer is colon cancer. And in the colon cancer, we have the apple core sign. On the radiology, we have the apple core sign. The most common cancer in acromegaly is colon cancer. The mismatch repair defect also leads to colon cancer. The next is if there is defect in the nucleotide excision repair. If there is a nucleotide excision repair defect, when this patient is going to go in the sunlight, see in our skin, there is some part of the DNA which is having multiple AT base pairs. A lot of AT base pairs are there in some part of our DNA. So when we go in the sunlight will fall on this DNA, and by chance, by mistake, the T molecules will club together and they will make the thymidine dimers. We don't want these thymidine dimers. So in you and me, these thymidine dimers are cut and we don't have any problem. But in some patients, these thymidine dimers nucleotides are not excised. And if the excision will not occur, the patient will develop the dry and pigmented skin. That is called as the xeroderma pigmentosa. So xeroderma pigmentosa, two questions to remember. It is due to persistence of the thymidine dimers and there is the nucleotide excision repair defect. And there is a formation of the thymidine dimers. Very good. The next is the missense mutation. The example of missense mutation is the sickle cell anemia. In sickle cell anemia, in our hemoglobin, we have total 4 chains of protein, 2 alpha chains and 2 beta chains. We have total 4 chains, 2 alpha and 2 beta. Sometimes in the hemoglobin, in the beta chain, at sixth position, the glutamic acid is replaced by valine. If the glutamic acid is replaced by valine, the RBCs are going to change the shape, and the shape of the RBC will like this, the crescent shape RBC. The crescent shape of RBC, and the RBC becomes very sticky. This is called as sickle cell anemia. The sickle cell anemia, also called as hand-foot syndrome. Also called as hand-foot syndrome. Sickle cell anemia is also called as hand-foot syndrome. Very good. The next is a question from the electron transport chain. In the electron transport chain, there are 3 questions. First, it occurs on the inner mitochondrial membrane. We all know what is happening in the electron transport chain. The basic concept is we want to convert the NADH, FADH into ATPs. We want to convert the NADH, FADH into ATP, that is called as electron transport chain. The first question is, in the electron transport chain, there are 5 complex enzymes, and they ask that they are pumping how many hydrogens, they are pumping how many electrons. So the mnemonic is 40, 42, 40, 42. The complex 1 pumps 4 hydrogen, complex 2 pumps 0 hydrogen, then 4, then 2. So 40, 42, 40, 42. Electron transport chain, the second question, 40, 42. How many electrons to be pumped by each complex 40, 42? The third is, who is going to inhibit the electron transport chain? What are the name of the inhibitors? Such as the rotenone is going to inhibit the complex 1. The malonate can inhibit the complex 2. Bal antimycin can inhibit the complex 3. Cyanide, carbon dioxide, carbon monoxide, hydrogen sulfide can inhibit the complex 4. So they ask this, who is going to inhibit the complex? The mnemonic is ro mat balak machhar kata hai. Ro mat balak machhar kata hai. Rotenone, malonate, bal, antimycin, kata hai, cyanide, carbon monoxide. But I want to add here, everyone remember right now here itself in this session, carboxyl inhibits which complex? Carboxyl inhibits complex 2. Carboxyl inhibits complex 2. Remember right now itself, carboxyl inhibits complex 2. Complex 2. The last question in the electron transport chain, see, normally NADH, FADH converts into ATP via electron transport chain. Sometimes the NADH, FADH converts into heat in the electron transport chain, and this process is called as uncoupling. This process is called as uncoupling. So they ask that who is promoting this uncoupling? Who can promote this uncoupling? There are many uncouplers, such as the thyroid hormone, thyroxine, and the important is 2,4-dinitrophenol. 2,4-dinitrophenol, that is the uncoupler. 2,4-dinitrophenol that converts the NADH, FADH into heat. So they will ask that which of the following is a pathological uncoupler? The answer is 2,4-dinitrophenol. So 3 questions. Electron transport chain occurring on the inner mitochondrial membrane. The how many hydrogens are pumped? 40, 42. When it comes to uncoupling, the uncoupler example, the pathological uncoupler is 2,4-dinitrophenol. 2,4-dinitrophenol. The carboxy, yes, there are many others. Yes, rightly said, aspirin, Sakshi, aspirin, it is there. But right now, we are just keeping the things to the point. The next is the various coenzymes and cofactor. Coenzymes and cofactor. Among this list, the important is the transketolase, the coenzyme is vitamin B1, transaminase, the coenzyme is vitamin B6, and methylmalonyl-CoA mutase is vitamin B12. Why these three are very important? The reason is, if you want to check someone is having the vitamin B1 or not, you are going to check the activity of transketolase. Transketolase. If you want to check vitamin B12 is there or not, you will check the activity of methylmalonyl-CoA mutase. And if you want to check whether the B6 is adequately there or not, you can check transaminase. So these three are the very important ones that, and among them also these two are very important. If we want to check vitamin B1 is there or not, we check the activity of transketolase. If we want to check vitamin B12 is there or not, we check the activity of methyl malonyl CoA mutase. And for vitamin B6, we check the activity of transaminase. When it comes to the cofactors, among the cofactors, the important is this one, the xanthine oxidase. Xanthine oxidase, the cofactor is molybdenum. For xanthine oxidase, the cofactor is molybdenum, and for succinate dehydrogenase, the cofactor is iron. These two cofactors important to be remembered. Succinate dehydrogenase, the cofactor is iron, and xanthine oxidase, the cofactor is molybdenum. Very good. The next is the vitamin A. Now coming to the vitamins, vitamin A deficiency, vitamin A deficiency can lead to several things. One is the night blindness. Second is the follicular hyperkeratosis. The hair follicles, there will be a lot of keratin deposition can happen. That is follicular hyperkeratosis that is seen with vitamin A deficiency. And third is vitamin A deficiency can also lead to the dryness in the eye. That is the bitot spot. Bitot spot. So vitamin A deficiency is night blindness, bitot spot, follicular hyperkeratosis that can be there. X1b, this is the WHO classification for vitamin A deficiency. X1b stands for the bitot spot. X2 stands for the corneal xerosis. Vitamin B2 deficiency. Vitamin B2 deficiency. Vitamin B2 is also called as the riboflavin. The active form of riboflavin is flavin adenine dinucleotide. Flavin adenine dinucleotide. If there is deficiency of vitamin B2, if there is a deficiency of vitamin B2, it will lead to glossitis, it can lead to chelosis, and the important is the new blood vessel formation, that is corneal neovascularization. Corneal neovascularization. Vitamin B2 deficiency leads to corneal neovascularization. Next is the vitamin B3. Vitamin B3 is niacin that is made from tryptophan. If there is deficiency, it can lead to pellagra. And from tryptophan, when we make the niacin, the name of the pathway is kynurenine pathway. From tryptophan, when we make the niacin, the name of the pathway is kynurenine pathway. The next is selenium deficiency. Selenium deficiency leads to Keshan disease. They ask that which vitamin contains cobalt. Which vitamin contains cobalt? It is vitamin B12. Because the name of the vitamin B12 is cyanocobalamin. Cyanocobalamin because it contains the cobalt. So selenium deficiency leads to Keshan disease. Which vitamin contains cobalt? Cyanocobalamin. Interestingly, in the exam, if a MCQ is there and you are unable to get any clue out of that MCQ, one of the alternate that you can use is try to search for some alternative names. Sometimes the answer can be there in the alternative names. So जब भी हम एग्जाम में कहीं पे भी अटकेंगे, we'll try to search for the alternative name, and that might give you some hint, right? Because see, what is happening is earlier you have seen the earlier pattern that was there was 150 MCQs were there in the first half, 150 in the second half. So there were two advantages that was there when the exam was happening in two slots. One, because you were having the access to 150 questions. So sometime, for example, the question number 22, you were confused between two options. And when you reached at the question number 141, you got a hint about the question number 22. It was possible. Sometime we get the hint of one MCQ in the other MCQ, and that way you could have came here easily and can access it and can mark it correct. So that was the additional advantage earlier. The second additional advantage that was there was earlier, because the exam closing time was here and here, so we were getting little anxious or some anxiety in just before the last few minutes, particularly in the second half we were getting little anxious right towards the end, because the second half was little lengthy and we can get a time crunch in the second half. But now, as the things has changed, there are going to be 6 such slots, so we are going to get anxious for 6 times. And one more thing that is going to be there is, if this question is here and one more question is related to this disease is here, you can't come back, you can't get the access to that. So these are the two losses that we are going to have. But as we can't change the things, we don't have much things and much thing that we can do about this, but what we can do is the practice. So now what I want is for the last these 10, 12, 14, 15 days, whatever is left, try to solve every day 50 MCQ slot. Not I am saying 50 MCQ, I am using the word 50 MCQ slot because I want your mental frame to be the same the way it is going to be asked in the exam. Means in the morning, say for example 9 a.m. you are starting doing the MCQ, you give yourself the time of 50 minutes and give you 50 minutes, whichever MCQ you want to do. Maybe from a single subject, maybe from mixed bag, whatever it is, whichever MCQ you want to solve today, do it in a 50 MCQ slot. Don't look at the answer immediately after finishing each question. First complete the slot and see that how much time it is consuming, and then you see the answers. So that every day if you are going to do this, you are going to do the 14 slots. Now 14 days are left to the exam, 13 14 days, so we will do 14 slots. In your exam there will be 6 slots, right? 50 questions, 6 slots are there. If you do 14 slots, basically it is equal to 2 GTs, it is equal to 2 grand tests. So without investing a single day, we are practicing for 2 GTs. The see, now many of you are asking that key, should we give any one more GT? Why we are asking this question is because in the last GT, many of us may have not get a very good score. Maybe 148, maybe 150, maybe 160. And we just want to reach to that 180 score in the GT. So we go to the exam with that confidence. Oh, 180 mera aaye the GT mein, so now I am going to pass only. See, the GT score is not going to make us pass. What is going to make us pass is the knowledge, is the practice of the MCQ, how we are going to implement it, right? And that way we have to prepare. We are not preparing to get a good score in GT. We are preparing to get a good score in the real exam, right? And what we are doing is we just want to get a good score in GT. So एक confidence आ जाए, बस 180 आ गया है, बस हम उसके लिए GT देना चाह रहे हैं. The idea should not be like this. The why we are giving the GT is to get acclimatized to the system. That has to be the idea. See, recently I have told in the class also that however hard paper they want to make, see, we can't stop them, we can't control them, but you will find at least 100 120 easy questions, 120 125 easy question in out of these 300 MCQs. They will be somewhere in between those MCQ. You have to control your nerves and you have to wait for those easy questions. The moment easy question, give more attention and make sure that you are making it correct. And if you get the maximum out of this, no one can stop you in clearing the exam, because you can see that out of 200 question yaar kuch to marks aayenge na yaar. It can't be zero. You will get something out of this and that will be enough to clear the exam if you just mark that easy questions correct. But what happens is, it's a human tendency that if we don't know continuously 5 question, even the 6 7 question is from your notes which you were knowing, we get anxious, right? Ab mera kya hoga, what is going to happen, the things are getting very worse, this time the exam is very difficult. The reason we feel the exam difficult is for 2 reasons. One, the language is slightly changed, not difficult, slightly changed, the words here and there. So we kind of get worried कि यार ये पेपर कहाँ से पूछ लिया, ऐसा तो हमने पढ़ा ही नहीं. You have studied everything. You just have to recollect the thoughts. Just try to rephrase the statement what they want to ask. Try to find that the simple words that ये पूछना क्या चाहता है, and then you can recollect the things and you can easily get the answer. I'm not saying that difficult questions will not be there. Difficult questions will be there. उनके ऊपर हंस देना है, आने दे. डिफिकल्ट दे रहा है, चलो आगे चलो, बाद में देखेंगे. There are easy questions are there. I just want to pick those easy questions. I have to make sure that I am making it correct. Why I am saying is because you are having the 50 questions slot, because there are only 50 minutes, and if you are doing the MCQ like this, that whatever answer is there for question number 1, first I will take it, then I will go to the second, then I will go to the third, then it might be there question number, let's say 5 11 12 13, they were very lengthy and you have invested so much time in that, said you are left with only 3 minutes for last 10 questions, and out of 10 questions they were very easy questions over there where you could have scored very well. So we have lost that chance, right? So what we are going to do is, when we are having the 50 slots, The first idea is out of 50 questions, at least there will be 17, 20 easy questions will be there, and I have to mark it correct. Just imagine, out of 50 questions, can't we make 17 or 20 questions correct? We can't. We can easily do that. 50 out of 50, 17 question is not a big deal, right? There will be easy 17, 18, 20 questions that we can mark, right? And first, say for example, the question number 1 was very difficult, 2 was very difficult. I will just smile, will go away. आ रहा हूँ, वापस आऊंगा तब देखेंगे, वापस आएंगे तब देखेंगे. I just have to find the easy questions which I know. I will tick them, and then I will recome, and then I will do these difficult questions also. So in that way, at least I am sure that कि मेरा easy questions तो सही हो गया ना यार. Second thing, don't change your answer. Whatever comes as the first you go, take that. Don't overthink. Don't overthink कि यार ये ऐसा पूछना चाह रहा होगा, इसने घुमा दिया होगा क्वेश्चन, यहाँ पे कोमा लगा दिया है, he wants to twist the things. Don't worry, right? See, these they were also made the paper, and the easy questions are easy only. Keep the things straight, keep your mental frame very stable in the examination hall. Don't get distracted from the difficult question. They are bound to be there. They are just to test your temperament. They are not going to decide the result. Listen the words, they are not going to decide the result. The result will be decided by these 180, 120, 125 easy questions. How you are making them correct. Just imagine that if someone makes maximum out of them correct, out of 100, 125 easy questions, if maximum is correct, then what is the difficult task that out of 200 question to get 50, 50, 60, 70 marks? It's not difficult. The reason why we are not able to crack the exam with a very good high pass percentage, because most of us gets breakdown, the nervous breakdown that happens in the exam because of this anxiety that कि क्या होगा यार, लगातार मेरे को 5 क्वेश्चन नहीं आए. I have prepared pharma very well, I have prepared biochem very well, and 5 questions continuously I was not doing right, and 6 question we lose the temperament, we lose the control on our nerves, and we start making the mistake, right? The same thing happens in the cricket also. You give continuous dot balls to a very good batsman, on the next ball he is going to make the mistake, right? So you just have to wait, my dear friends, and the things will start coming to you, and definitely you are going to make it. See, आपने इतनी मेहनत की for last 5 months, and these 10-15 days, we can't just let it go like this. My sincere suggestion to you is flip the pages as much as you can. Flip the pages very quickly. Don't give the time to your brain to think the random things, the random thoughts, because the moment you stuck somewhere on some pages, your mind will start deviating. He will tell you यार ये यहाँ से नहीं हो रहा, वहाँ से rapid revision से कर लेते हैं, ये कर लेते हैं, वो कर लेते हैं. No, your notes are gold. Stuck to that. If some pages where you are not able to overcome the things, it's taking a lot of time, don't worry. Quit that topic. Just whatever the teacher has told कि यार ये 2-3 चीजें बहुत important है, just focus on that and move to the next page. That flipping pages is going to release a lot of dopamine in your brain, and you will be so much indulged that the random thoughts will not come to your mind. And that way, these 13-14 days we are going to utilize to the best. Don't run here and there, here and there. Stick to your notes, and you are going to make it happen. See, you are just not doing this thing for you. The entire family is waiting for that one result, that one day, that they are patiently waiting for last 6 years, 7 years, right? They have invested everything, and we can't just let it happen for 14 days. It's like a war situation for us, right? Just imagine that if someone has gone to a war, राइट जब कोई वॉर पे जाता होगा आज से 300 400 500 पे पहले जब वो तलवार से लड़ते थे, राइट, एट दैट टाइम इफ द वॉर इज गोइंग ऑन, इज देयर एनी थॉट दैट केम टू देयर माइंड कि यार कमर दर्द कर रही है, सिर दर्द कर रहा है, या समझ में नहीं आ रहा है, लेट्स टेक अ ब्रेक, चाय पीने दो, बीड़ी पीने दो, राइट? सच ब्रेक्स नेवर हैपेंस, राइट? इफ इट इज अ वॉर नथिंग कम्स टू द माइंड, एंड दिस is the war time, that such no thing should come to your mind. If it is coming to your mind, means we have to correct our mental frame. Kamar the chai bidi, everything will be secondary, right? Everything is secondary, everything will wait. Just flip the pages, and if you do that thing, you can till from today onwards, if you start flipping the pages continuously, you might flip your entire syllabus maybe for 2 times, 3 times. But if you stuck, if you are thinking that कि मेरे को याद आएगा नहीं आएगा, डेफिनेटली आएगा ना यार. 3 बार पढ़ लेंगे. अगर अपन 3 बार किसी चीज को 3 times, if it is coming to your in front of your in the eyes in the last 14 days, how it is possible that you will not remember that in the exam? It is going to be there. So don't have to worry. हाँ, वो फोमो वाला जो प्रॉब्लम है ना, दैट दैट इज वन थिंग दैट यू हैव टू ओवरकम. कि यार वहाँ पे पता नहीं क्या पढ़ा रहे होंगे, वहाँ पे क्या चल रहा है, वो मिस नहीं हो जाए. आई हैव टू दिस दैट, आई हैव टू डू दैट ऑल्सो. इज नथिंग लाइक दैट. डोंट वरी. These notes are more than enough to clear your exam. The things, even right now today, if someone gives you that 300 MCU right now, right, you will be easily able to crack the exam right now. This much amount of enough is because right now you don't have the nervousness. You give the exam, you clear it. But in the real exam, those 300 MCU, you might not score that good. The score that actually you get is -20. If your real score is 170, then you are getting 150 only, because you are having the knowledge to get at least 170 as 170 plus, but we are just getting 150 plus. The reason being the nervousness, that pressure force you to do the mistakes, and we are not let it happen, because we are going to practice in this way. So every day do 50 MCQ in a slot. It will not take much your time, guys. And it was a very short and a crisp session that I want to have with you. And I was thinking that it would have taken maybe 2 hours, but we have just completed in 1 hour 15 minutes. But most of the things we have tried to cover from all the major units. Why it has not taken much time, although we have covered so many topics, because we have just kept to the point. We don't have went into the concept, right into the concept, but we just went to the clue words. So that way it has not taken much time. So, and don't overthink about the exam dates. Just keep it simple. Yes, it is going to happen on 6th of July. Why we are see why our brain gives you that random ideas? Because we just want to escape the things, right? So in most of the situation, it is going to happen on the 6th of July only. Let's keep that thing. Let's work hard for your family, and definitely you are going to make it happen. The Almighty is looking at you. The hard work that you have did in the last 4 5 months, the justice is going to happen. The hard work is going to be paid off. It is not never going to be in vain, right? So wish you all the very best. Keep this hard work going, and we will be in touch. If anything, you can write me down, and I'm very sure sorry that if I will not able to answer you, just write it down again, and I will try to answer you. And if not, you can call anytime, right? And we'll discuss the things on the phone. No need to write in the WhatsApp that when I can call you. You can call anytime. You call anytime, we'll try to answer. But the whole and sole agenda is the exam has to be cleared in this attempt only. This is the whole and sole agenda. You and me both we are having, and a lot of family members are waiting back, right? And you are definitely is going to make it happen. Okay, my dear friends. So we'll finish the session here. Thank you, and we'll be sharing the PDF with you in a while. Thank you, guys.